Good morning, everyone. I'm Carlene Pavlos. I'm the Executive Director of the Massachusetts Public Health Alliance, and we are just thrilled to be here today. There are more than 500 people registered for today's event, and we hope and believe that that speaks to our alliance, that it speaks to the fact that those of you who are here with us this morning don't just think that health equity and racial justice, which is the core of MPHA's public health work, you don't just think they're good ideas, but you're committed to being part of the ongoing movement that drives towards those goals. It's inspiring. It's so inspiring to be here with all of you today. As you all know, the theme for today's conference is Resolve, Not Retreat, Public Health in the Face of Authoritarianism. I want to say that we thought really intentionally about the words for that title. And I will admit that I was wondering if it might be too much. It chills me to have to use the word authoritarianism. But that's what we're facing if we don't act, and act in alliance with strategy, with shared power, and with a commitment to justice. So we do need to say those chilling parts out loud. So that means that we're even more grateful for you being here with us as we face the truth and build our resolve, build our resilience, and build our strategy for moving forward. We have a very important agenda today. I call it an important agenda because we'll be hearing from allies at the Massachusetts Department of Public Health about the work that they're doing from the inside to push back against the cruelty and chaos and to keep residents safer and healthier. Commissioner Goldstein will be providing our keynote address, as you all know. And later, he'll be joined during his presentation by three other DPH leaders. Dee Calvert, who is the director of the Bureau of Substance Addiction Services, who will be talking about the work DPH is doing on harm reduction and syringe exchange, as well as other strategies to close the gaps in overdose outcomes among particular populations at high risk. Jill Clark, who is the director of the Division of Child and Adolescent Health and Reproductive Health, who will talk about the work she and her team are doing in the reproductive health and school-based health and youth development spaces. And Dr. Fifi Diop, who is the Assistant Commissioner for Health Equity, will offer perspectives of the work underway to advance racial equity, work that DPH is continuing despite the pronouncements of the federal administration. Now, before I go any further in the morning, I want to thank our sponsors. We have amazing sponsors. You saw their names going on the slide loop earlier. And I hope you take a moment to check out the complete listing that is in the program materials for today's meeting. We especially want to thank Dana-Farber. Dana-Farber, their Office of Community Health, is just such a consistent supporter and partner of MPHA in our work. And we are really grateful for their sponsorship for this conference, because it's one of the ways that we were able to keep costs ridiculously low for the conference. And it's really a pleasure to have a funder that shares our values. So we're super grateful for their support. Now I get to introduce Dr. Goldstein. Robbie Goldstein has served as the Commissioner of the Massachusetts Department of Public Health since only April of 2023. I'm sure he feels like it's been longer than that, because in his relatively short time, he has really left quite a mark. In addition to elevating health equity to an assistant commissioner level, under his leadership, the department has created a health equity strategic plan that they continue to implement despite federal pushback. Commissioner Goldstein has also led not only Massachusetts, but the region in developing policies to bring peer-reviewed science back to vaccine policy in the face of federal, let's call it evidence-free vaccine policy. And he is just an incredible ally to all of us who value public health. We're thrilled to have him here with us today. Later in his presentation, the commissioner will be joined, as I said earlier, by 3 members of his staff, and I want to introduce them now so I won't interrupt you later. Dee Calvert has been the director of the Bureau of Substance Addiction Services since 2019. Prior to that, she was a practicing clinician. She's used both her clinical and leadership skills to steer the department's work in addressing the opioid crisis in Massachusetts, and it's so great to see that that work is beginning to show progress. Jill Clark is the director of the Division of Child and Adolescent Health and Reproductive Health at DPH. She's had a long career at the department, and at each and every step of that career, it has been marked by a deep commitment to young people and to abortion access and reproductive justice. Dr. Fifi Diop is the Assistant Commissioner for Health Equity at the department. Prior to that role, she worked in maternal and child health, spearheading the efforts to address the dramatic inequities in birth outcomes based on racism. I hope you'll take a moment to review their complete bios. These are amazing women, and the commissioner is just such an ally, and you should learn more about them. We are really lucky to have such committed government leaders. They're not only capable and committed themselves, but they are true partners to those of us who work on the outside. So, Commissioner, I hand it over to you.
Thank you, Carlene. Good morning, everyone. Thank you for inviting me back again this year. It's such a privilege to be a part of the Massachusetts Public Health Alliance annual conference. This year, for so many reasons, feels different. It feels more urgent. Being with you today feels a bit like me to an act of solidarity. I want to start by applauding the bold name that you've given this year's conference. Resolve, not retreat. Public health in the face of authoritarianism. It's formidable. It's a fitting title, and it speaks to the challenging moment in which we live. It's a charge to all of us, a call to answer the urgency of our times. We're here to do exactly what your conference materials declare so unflinchingly. Quote, in a time when democracy is under threat, science is sidelined, and our most impacted communities are targeted, we come together, not to retreat, but to rise. Those words are powerful and motivating, and honestly, they make me proud to be in Massachusetts, to be in coalition with all of you. Because when the times are hard, MPHA does not shrink. It gets louder, clearer, more determined, if that's even possible. You are extraordinary advocates for public health and for the communities we serve, and I am deeply grateful for your partnership, your leadership, your persistence, and your profound commitment to what truly matters. We need that moral compass today more than ever, because right now, we stand amidst one of the most turbulent eras our field has faced in decades. Misinformation and disinformation seep into public discourse and erode that all-important trust in public health. These destructive forces have metastasized, targeting science, chipping away at public trust, and attempting to destabilize truth itself. In this climate, lies echo so loudly and so frequently that they begin to sound like truth. Even the most baseless rumors, the ones that science disproved a long time ago, can begin to sound plausible. So deliberate confusion is used to undermine experts and institutions. It's used to plant those dangerous seeds of doubt. And I know that for many of you, just like for the staff at the department, there are moments when you may think, how can we keep doing this? How do we keep going when the ground seems to shift beneath us? I want to acknowledge that these feelings are real, they're honest, and they're understandable. But here's what I tell our team at DPH and what I want to say to all of you today. This is a time when public health can and should and must shine. This is a moment when we have to work harder to move forward and not step back. It's a moment when we must not alter who we are or compromise what we stand for. This is a time to recommit fully, resolutely to our mission and to the people of Massachusetts. The beauty of public health has always been its compassion and its values. Its strength lies in the people who do this work. who support this work, advocate for this work. Its strength also rests in our shared purpose and in our ability to stay nimble and adapt to new threats and evolving challenges. And make no mistake, this moment is testing all of that. Right now, we're seeing troubling decisions at the federal level, decisions that often feel random, reactive, and disconnected from long-term consequences. Decisions that undermine decades of progress in science, prevention, and evidence-based practice. I recognize that many people who work in public health feel anxious about their jobs in this current climate. These concerns are valid, but I want to emphasize this. What you do every single day matters deeply. It matters to the safety of our communities, to the strength of our systems, and to the future of our state. And it's more important than ever that we face these challenges together. Our work in Massachusetts must move forward, guided by facts, compassion, and science, not by partisanship or ideologic agendas. We have strong partners in these efforts, and I'm proud that our governor, our attorney general, and our legislature have stepped up boldly and taken important measures to reaffirm our commitment to vital issues like reproductive rights and gender-affirming care. Massachusetts will continue to be a safe harbor for legally protected care. We will keep shielding patients, providers, and advocates from punitive federal overreach, and will continue to uphold the rights, the dignity, and the safety of all who seek essential health services here. At the same time, we're watching a disturbing and growing backlash against health equity work. Let me be very clear about this. Our department's commitment to equity is not optional, nor is it negotiable. Health equity work is the work of public health. It's the core to who we are. It's how we measure our success. And it's how we make good on the promise of public health for all communities. We also continue to see misinformation undermine trust in vaccination, and the consequences are heartbreaking. Across the country, measles outbreaks have occurred and are occurring in communities that were once free and protected from this serious disease, one that in the year 2000 was considered eliminated. Pertussis, or whooping cough, another vaccine-preventable disease, is also increasing. And sadly, vaccination rates have continued to fall as the highest levels of government cast misleading and dangerous shadows over one of the greatest scientific achievements in human history. The evidence and the data tell us just how important vaccination has been. According to the World Health Organization, vaccines have saved more than 154 million lives in the last half century. That's one life every 6 minutes. And UNICEF estimates that the measles vaccine alone has saved nearly 94 million lives. These are not abstractions. These are our neighbors, our families, our children, our communities. This is why our work matters. Massachusetts has been and must remain a national leader in public health, not in spite of these difficult times, but because of them. Because we will rise to meet every challenge that comes our way. And I want to give you some examples of how we in Massachusetts and at DPH are moving forward with persistence, strategy, and resolve. And I'll start by exploring our vaccine journey even more deeply. Several months ago, as federal actions around the fall respiratory virus season became increasingly delayed and unpredictable, access to basic vaccinations suddenly seemed at risk. FDA approvals came with unexpected restrictions. CDC's Advisory Committee on Immunization Practices, ACIP, postponed its meeting for weeks. Providers and pharmacists were left in limbo, and the public was left without clear science-based guidance. We were not willing to let that uncertainty jeopardize our communities, so we acted. DPH issued a standing order authorizing pharmacists across Massachusetts to continue dispensing and administering all recommended COVID-19, flu, and routine vaccines based on science and evidence, not based on shifting federal winds. We extended similar authority to qualified personnel and local boards of health so that every community, regardless of size or resources, could continue vaccinating people who wanted and needed protection. At the same time, we took unprecedented steps to secure insurance coverage. At Governor Healey's direction, DPH and the Division of Insurance issued a joint bulletin requiring Massachusetts insurers to cover any vaccine recommended by DPH. Again, not just those recommended by the federal advisory committees, whose processes had become increasingly unsettled and dubious. And the Board of Registration in Pharmacy went further, voting to give the Commissioner of Public Health, yes, me, not the federal agencies that we had once counted on, the authority to determine which routine vaccines pharmacists may administer. With this shift, Massachusetts became the first state in the nation to guarantee both access and coverage for state-recommended vaccines, helping residents of our state remain protected, regardless of confusing or questionable federal decisions. We acted early, we acted together, we acted based on science. And in so doing, we sent a clear message that in Massachusetts, we will not allow ideology to override evidence or politics to stand between our residents and life-saving care. Beyond preserving access to vaccines, Massachusetts has acted with equal urgency on other fronts where federal decisions have threatened the programs people depend on. In partnership with our Attorney General, we've joined with states across the country in taking legal action to defend essential public health funding and services. We filed suit against the U.S. Department of Health and Human Services for abruptly and unlawfully terminating more than $11 billion in critical public health grants, funds that support everything from disease surveillance to maternal and child health programs. We also joined litigation against the USDA for suspending SNAP benefits during the federal government shutdown, a move that had placed thousands of families at risk of losing the nutrition support they relied on. And when federal executive orders targeted diversity, equity, inclusion, and accessibility efforts, including programs that support transgender individuals, we stood firmly with other states to challenge those actions and protect the people and the principles at the heart of public health. We also worked alongside state partners to issue joint statements defending reproductive care and preserving access to mifepristone, supporting residents in Massachusetts and throughout the region who deserve to have seamless access to this safe, evidence-based, time-sensitive medical care. Here at home, we reinforce those protections by updating and expanding our Know Your Rights guidance on abortion care, contraception, and the safeguards offered under our state's SHIELD law. And we are proud to join with 17 state attorneys general in opposing a federal effort that threatened to strip funding from long-standing teen reproductive and sexual health education programs unless states remove language affirming young people's gender identity. That federal demand would have jeopardized our funding for the Personal Responsibility Education Program, or PrEP, undermining essential education on pregnancy prevention, healthy relationships, and sexually transmitted infections. We made it clear Massachusetts will not be coerced into abandoning health education that saves lives, fosters safety, and affirms the dignity and identity of every young person we serve. We've also deepened our partnerships with other states to strengthen our collective ability to respond to emerging threats. Massachusetts is a founding member of the Northeast Public Health Collaborative, an alliance of states and major city health departments committed to sharing resources, coordinating our responses, and restoring confidence in science-based medicine. Collectively, we're addressing the kinds of challenges that pay no attention to state borders or city lines, like infectious diseases, emergencies, climate and environmental threats. The Northeast Collaborative facilitates planning and implementation of public health activities across our region that can benefit communities through unified, coordinated, and strengthened action. The collaborative is helping rebuild trust in public health in a moment when trust is essential. And throughout all of this, we've remained committed to transparency with our staff, with our local and regional boards of health, and with the communities we serve, because the foundation of true partnership is honest, open communication. It's how we retain and build trusting relationships. So I've spent the last 10 minutes or so telling you in very overarching ways what we're doing to protect communities, to preserve health and well-being, to build trust and to push back on the decisions, actions, and disruptive forces that have been coming at us relentlessly. I want to now offer you a closer look at some specifics and some very important services and programs that will show you how our approach has changed to respond to these times. I'm honored to be able to share this platform with three extraordinary DPH leaders. They're going to give you a glimpse into the real challenges in their areas of responsibility. More importantly, they're going to share how they and their teams are working every day to maintain progress and uphold the commitments we've made. So first will be Dee Calvert, who directs our Bureau of Substance Addiction Services. She'll be followed by Jill Clark, who leads our Division of Child, Adolescent Health and Reproductive Health. And then you'll hear from Dr. Fifi Diop, Assistant Commissioner for Health Equity. Their approach and their leadership in confronting the challenges that we face exemplify the spirit and the resolve that are threads running through everything we are doing to fulfill our mission in this extraordinary time. With that, I'm going to pass it on to Dee.
Thank you so much. Good morning, everyone. As stated, I'm Deirdre Calvert. I go by Dee, and I'm the director of the Bureau of Substance Addiction Services, or BSAS, at the Massachusetts Department of Public Health, having served in this role since April 2019. I am a licensed independent clinical social worker, and I worked as a clinician and provider in the field of substance use disorder and co-occurring disorders for more than 30 years prior to coming to the state. I want to really thank Commissioner Goldstein for the opportunity to join him today, and of course, the MPHA. I'm thrilled to give some updates from BSAS. At a time when evidence-based supports for people who use substances are increasingly under attack, it is critical that we take advantage of opportunities like these to connect and to remind ourselves of the great work we continue to do. So next slide, please. So for those who may be unfamiliar, the federally designated single state authority for substance use is BSAS. And BSAS develops, implements, and oversees prevention, treatment, harm reduction, and recovery support services throughout the Commonwealth. Additionally, BSAS provides technical and training and technical assistance to the workforce and promotes non-punitive approaches to substance use care. Next slide, please. And all that we do is guided by our mission to support accessible, effective, and culturally responsive principles, programs, and practices. And I'd like to take a few minutes now to highlight some of our recent successes and priorities. Next slide, please. So earlier this year, we received some heartening news. According to the CDC data released in May, opioid overdose deaths in Massachusetts decreased by 36.3% in 2024, falling to the lowest rate since 2013. This decrease was seen across all races and ethnicities. This was not through luck. This was not by accident. This was due to implementing evidence-based harm reduction and treatment priorities. Next slide, please. Here on BSAS's publicly available data dashboard, you can see the confirmed and opioid-related overdose deaths through 2024 mirror the downward trend reported by the CDC. This news is encouraging, and as I said, it's a testament to the persistence and dedication of all who continue to work tirelessly across the Commonwealth to support people who use drugs. This also shows us that when we use support evidence-based tools and approaches and promote health and safety for persons who use substances, it works. One thing we know for sure that does not work is criminalization. Criminalization has never prevented an overdose. Next slide, please. So next, we're going to talk a little bit about IPSI work, which is our infants prenatally substance exposed. In all of our efforts at BSAS, we remain committed to ending the criminalization of substance use, as I said earlier, and prioritizing access to healthcare and clinician-led decision-making. As part of our efforts, BSAS is working to implement changes to mandated reporting and family care planning related to infants affected by prenatal substance exposure. While there is a critical need to screen for and identify substance use during pregnancy for improved access to treatment, recovery, and harm reduction services, For too long, our regulatory and statutory requirements required providers to universally report parents and parenting individuals using substances or even taking medications for addiction treatment and report them to child welfare for abuse and neglect. While well-intentioned, these rules have strained provider-patient relationships and forced people who use substances further into the shadows out of fear of punishment. BSAS has been working with the Department of Children and Family Services and the DPH Bureau of Family Health and Nutrition to forge a better path forward to support families in a more equitable and strengths-based way. With the help of the legislature, we changed the law requiring abuse and neglect reports be filed for every infant born prenatally exposed to substances. Now, mandated reporters are expected to use their clinical judgment to assess for abuse and neglect instead of the state making that decision for them. But our work does not stop there. We are drafting regulatory changes, providers' guidances, and comprehensive trainings, toolkits, and technical assistance so that providers and families are supported in their wellness and recovery journeys. These changes will focus on ensuring universal screening for substance use in birthing people, having providers participate in collaborative, patient-led family care planning, and addressing regional gaps in access to services. We look forward to having a structured and sustainable family care plan coordination system to ensure each family has access to wraparound supports while they navigate recovery and parenting postpartum. We are also still collecting and analyzing data for infants affected by prenatal substance exposure and doing through a DPH notification, and not just through a DCF abuse and neglect report. With these changes, we hope to foster improved linkages to treatment and parenting resources, and truly decreasing barriers due to stigma, discrimination, racial bias, or geography, and to ensure that families that receive support necessary for healthy pregnancies and healthy lives. Next slide, please. So at BSAS, we're also focused on health promotion, and one area that we're currently focused on is alcohol use. So alcohol is one of the most commonly used substances in Massachusetts, and alcohol continues to impact the health and well-being of individuals in the Commonwealth. In Massachusetts, alcoholics drink and binge drink more than the national average, while Massachusetts youth, 12 to 20, are similarly more likely to drink or binge drink comparatively. We know that alcohol can lead to negative outcomes and harms in both short and long term, and we can see this reflected in the Massachusetts data. Alcohol causes close to 1 in 4, or about 3,000 deaths per year in the Commonwealth, including alcohol-caused liver disease, cancers, alcohol-attributable heart disease and stroke, vehicle crash deaths, and more. Next slide, please. Proportionally, alcohol-related ER visits in Massachusetts are high among substance use-related ER visits, and this is through our data dashboard. For example, in 2024, we saw over 80,000 alcohol-related visits to the emergency room compared to the almost 10,000 due to opioids. Please note the difference of the scale in these two bar charts. The alcohol-related visits are 8 times higher. At BSAS, we want to ensure that residents of the Commonwealth are well informed and have accurate information about the health impacts of substance use, including alcohol, and be able to make their own decisions, as well as be able to access services and resources if and when needed. It is also important to consider that culture and environment have shaped how we think about alcohol and perceive risks related to alcohol use, specifically in Massachusetts. And to this end, we are working on developing a strategy to address alcohol and health in Massachusetts. As we move forward with this work, we welcome partnership on this topic. Next slide. So thank you again for the opportunity to talk about these 3 important updates, and I am happy to stay for questions after. Thanks.
Thanks, Dee. Then we're going to move on over to Jill.
Thanks so much. Good morning, everyone. And I'm so delighted to be here with all of you today and really appreciate the Commissioner inviting me to come and speak along with him and these other wonderful colleagues. And thanks to MPHA for having us. My name is Jill Clark. I use she, her pronouns, and I direct the Division of Child and Adolescent Health and Reproductive Health at the Department of Public Health. Real quickly, an overview of some of the programs included in my division. We have a number of school-based health programs, including school nursing and school-based health centers, our Office of Youth Mental Health and Wellbeing, our Office of Sexual Health and Youth Development, and our Sexual and Reproductive Health Program. And there's a couple of through lines between all of those programs. One is that many of those programs, all of those programs serve adolescents in some way, although many of those programs do serve people of other ages. But it also means that many of these programs are delivering services related to stigmatized healthcare or stigmatized populations. And so that's been a real challenge in this environment. And I want to tell you about a couple of the activities that we've had taking place recently. So first, in the realm of sexual and reproductive health, Massachusetts has passed not one, but two SHIELD laws that protect patients and providers that are receiving care and providing care in Massachusetts. And they also allow our providers to offer care to individuals outside of Massachusetts, particularly folks who are coming from states where that care is stigmatized or criminalized. The SHIELD laws in Massachusetts protect both abortion and abortion-related services, as well as gender-affirming care, and protect those providers to provide that care in Massachusetts and to people outside of Massachusetts as well. In addition, the department is convening an abortion task force that is tasked with providing additional recommendations for how we can respond if federal funding is disrupted for abortion providers or if there's other disruptions in abortion access. You may have been hearing about efforts to restrict Medicaid funding from providers that offer abortion services. That has already happened for some providers, both inside and outside Massachusetts, and we expect that that may expand. And so this group is working on making recommendations for what to happen, what needs to happen if that effort expands, and we expect that report to be available in early 2026. Second, we're providing a large amount of support to young people that are in schools. We know that many young people are struggling. Youth mental health was poor before the pandemic, and the pandemic did not help. And we also know that young people spend a lot of time in school, and providing services in schools is one of the most effective ways that we have to reach young people where they are. So the department supports several programs that expand access to behavioral health services for young people, particularly in schools. We do this through our school-based health centers, which are satellite primary care clinics that are physically located in schools that offer a robust amount of primary care and behavioral health services. We do it through school staff directly, both school nurses, school guidance counselors, and also by providing funding to schools to expand the number of staff that they have that can offer support to young people in schools. And we're also doing it through telehealth services so that young people can access behavioral health services physically located in the school without leaving school, accessing a provider that is not present in the school. We also provide a lot of training and technical assistance to support the adults that are working with young people and working in schools. One effort that we're working on is to ensure that schools have equitable policies that assure non-discrimination and non-punitive approaches to substance use. As Dee mentioned, punitive approaches don't work. And so we really want to make sure that when young people are identified using substances or with substance problems, that schools have non-punitive approaches to help them manage their substance use. We also work with all schools to ensure that schools can safely administer medication in schools so that students who need medication during the school day can safely attend school. And finally, we've worked with a community-based organization over the last year to help adults working with young people to support transgender and non-binary youth, both in schools and in the community. Finally, I want to elaborate a little bit on what the Commissioner mentioned about our work in adolescent sexuality education. The federal government, we provide sexual and reproductive health services and sexuality education in community-based organizations and schools, and we do that through both state and federal money. However, the federal government issued a notice of noncompliance to the Department of Public Health in September, notifying us that our federally funded comprehensive sexuality education program could no longer include information on what the federal government calls gender ideology. At the department, we quickly determined that it was absolutely not possible for us to provide comprehensive and medically accurate sexuality education without the inclusion of gender identity and the opportunity for students to learn about variations in gender identity and to ask questions and receive answers about their own gender identity. So in early October, 16 states, including Massachusetts, sued the federal government to say that we wanted to be able to continue to include this information in our sexuality education curriculum. And on October 27th, the federal judge issued a preliminary injunction, which preserves the status quo. So that means that the federal government cannot withhold our funds or cannot impose new contract conditions related to prevention of conversations about gender identity. And this means that we can continue to provide adolescent sexuality education through our current partners, which are 4 community-based organizations and 7 school districts that we work with directly to provide these services. So we're really so grateful to be able to continue all of this work and more things that I didn't have time to talk about, even in these challenging times. And I want to thank you for the opportunity to speak and pass it back to the Commissioner.
Thanks, Jill, for those remarks and for all the work. And finally, we're gonna, but certainly not least, we are gonna pass it on to Dr. Fifi Diop, who's gonna talk to us about the work that we're doing in health equity.
Good morning, everyone, and thank you, Commissioner Goldstein and MPHA, for creating space for this conversation at such an important moment for public health. I'm Fifi Diop, Assistant Commissioner for Health Equity at the Mass DPH. As we all know, this is not an easy time to work in public health. Federal decisions are reshaping the field we love, and yet, as the Commissioner mentioned, at the Department of Public Health, we continue to lead, not by words, but by action. So we are not just talking the talk, we are walking the walk. We are holding firm to a simple truth. Public health work is health equity work. As many of you know, last year, we launched our strategic plan to advance racial equity, known as SPARE. SPARE is more than a plan. It's a shared commitment to transform how we show up as a department. It asks us to look both outward and inward, to advance racial equity through our programs and policies, and to embody those same values within our own workforce. In this political moment, SPARE is our blueprint for resilience. It's how we protect what matters most, our people, our purpose, and our promise to the Commonwealth. One of SPARE's strategy areas, strengthening the public health workforce, has become a cornerstone of our progress. We cannot deliver equity externally if our staff are not supported internally. That's why we are investing in what I call the people's side of public health, the well-being, morale, and growth of our workforce. Earlier this year, we conducted our first department-wide racial equity staff survey. This was a milestone, our first real look at the lived experiences of staff across bureaus, offices, and hospitals. The findings were honest and at times uncomfortable, but also deeply hopeful. They showed us that our staff want to lead, to learn, and to build a workforce rooted in psychological safety, compassion, and accountability. These are data we can act on, and we are. Each bureau, office, and hospital at DPH will be using the results to improve leadership practices, strengthen promotion and retention pathways, and foster spaces where every employee feels seen, heard, and valued, because health equity doesn't start with a community program. It starts with us. If we want to be the trusted messengers and defenders of equity across the Commonwealth, we must first model that within our own walls. This is how we build capacity, not just to withstand federal rollbacks, but to lead recovery and renewal across our systems. So the message I want to leave with you today is this. Even in times of constraint, we can still choose courage. We can choose to center the people doing the work, our public health workforce, as the foundation of any true equity efforts. Massachusetts continues to lead, not because the path is easy, but because our commitment is unwavering. Together, we are showing the nation what it looks like to advance health equity, not as an aspiration, but as a living practice. Thank you.
Thank you, Fifi. So as all of you can see, I hope, from this ongoing work and from the passion that fuels the work, public health is not and will not take a pause during difficult times. We keep going, we push forward, perhaps harder than we ever have before, in a moment when our field is being challenged as never before. As we look ahead to the coming year, to the opportunities and the hurdles before us, our work will continue to be shaped by the strength of the partnership between DPH and MPHA. We've weathered extraordinary storms together, and it's together that we'll get through this one as we stay the course to build a healthier, safer, more equitable Massachusetts for every resident and every community. So I want to end by thanking you for your partnership, your dedication, your unshakable commitment to public health, and I'm looking forward to your questions. I think I'm turning it over to Omi.
Thanks so much. Hi, everyone. I'm Omi Amarasingham. I'm the Deputy Director here at MPHA. We're so glad to be with you all this morning. And thank you so much, Robbie, Dee, Jill, Fifi, for your wonderful presentation, for all of your work in this very uncertain and scary time. It is, I know everyone on the webinar knows, it is a tough time for public health. Public health is squarely in the crosshairs of this federal administration, and it's also personally very painful because I know all of you, many folks on the call are responsible for so many important advancements in public health, and to watch that just be dismantled so rapidly and so callously has been really difficult. So I'm really glad to be with all of you today and to share in our resistance and put our resistance in action. So I have a couple questions to get us started that people submitted when they registered for the event. And for people who have more questions, please make sure to pop them in the Q&A button that's at the bottom of, well, it's at the bottom of my screen. I guess I don't know where it is on your screen, but somewhere in the Zoom screen. And we'll take audience questions that way. One other thing that I'm always grateful for about all of you is you run on time. So we have plenty of time for the Q&A. So please keep the questions coming in. Picking up a little bit where Fifi left off, we had a great question come in from Liz O'Gilvy from Springfield, who is one of MPHA's beloved Policy Council members. And maybe each of you can answer this from the perspective of the work that you oversee and do in your own part of the department. But how will Massachusetts Department of Public Health keep talking about racial health disparities in this moment of anti-DEI? We have seen huge attacks on diversity, equity, and inclusion coming from the federal government, including severe losses of funding. And I know many of us in the nonprofit sector are very wary about what we can say and what we can't say and how we might risk funding. I'm wondering if that's also a concern on your end. And even if it's not, how are you all thinking about and making sure that you're advancing racial health equity in this time? Maybe Robbie will, I don't know. Do you want, I'm actually not sure. How should we direct questions? Everyone can jump in, or Robbie, you could direct them for me.
Yeah, no, I'm happy to start, and Fifi, I'm sure, has a lot to say here. And I will acknowledge that so much of my perspective on this is informed by Fifi and her leadership and the work that she's doing. I think we have to start by acknowledging something that is happening at the federal level, which is conflating the work of diversity, equity, inclusion, and accessibility with the work of public health and health equity. And while the two are linked in many ways, and there are important links between them, the work of health equity, of understanding racial disparities, of addressing the outcomes that we see in racial and ethnic minority groups across the country, that work is the work of public health, right? And we're not going to back down from that. And I think that's what you heard from all of us today, that we continue to keep that central to our work. And I actually don't believe that it's in conflict with what this current federal administration is asking for. They're asking for us to focus on outcomes, and we will focus on outcomes. We know that Black women in Massachusetts disproportionately experience severe maternal morbidity and maternal mortality. And that means we need to direct our efforts to address Black women and their access to healthcare and their access to supportive services around the time of delivery. That is not going to change in any way, and we will march forward with our health equity work. Will we use different language in our reports back to the federal government? perhaps, so that we can make sure that the funding continues to flow to the Department of Public Health and into Massachusetts. But at the core, our work is not changing at all. Fifi, I know you have a lot to say on this, so I'll pass it to you, but Jill and Dee should also jump in afterwards.
Thank you so much, Commissioner. That's well said. What I would like to add is that we should remember what is our purpose. We intentionally at DPH decided not to change our mission statement. We said we are serving the people of Massachusetts, and we are doing that with the lens of equity, and that is not changing. Second, we need to go back to the communities that we are serving to work with them, partner with them, hear them, and co-create solutions and be innovative. If the federal government is smart, we should be smarter. Third, we have data that shows that outcomes are different by race, ethnicity, by geography, by disability status, by gender identities. So it is important to address the needs. We go after outcomes that are bad and we try to fix them. So that's essentially the core of what public health does and has done well. So I think we should just remain centered. It's important to remain centered. The whole administration is trying to make us be confused and disparate, and I think we should remain centered. I also believe that partnership is the key. This is the time people should come together, work together, and we are so glad to be here with you at MPHA to continue to really build on those partnerships. Help us, you can help us where we're lacking, and we can help you where you're lacking. The department is good at providing data, using data to show where outcomes are different, but the department does not always have funding, and other organizations may have funding, may have community-based organizations. There are a lot of ways we can come together in this partnership to improve the lives of our residents. So I'm going to leave it at that and allow Jill and Dee to add.
I'm happy to jump in. We are absolutely resolute in our commitment to communities of color and to racial and health equity across the board. As I said in my talking points, we saw the decrease was also across all races and ethnicities. And that is really truly due to the work of harm reduction and trying to meet people where they're at. And as Fifi said, really asking communities what works. Why are methadone clinics still mostly white? How can we reach communities of color? We know that in the alcohol data that I very briefly presented on, more white people are drinking, but more Black men are dying from alcohol-related diseases. We cannot keep take our foot off the gas, and we cannot allow this to happen. Some of the things that we really worry about is that due to, immigration and really punitive, cruel outreaches by ICE and things like that, we're very concerned about people accessing our treatment and our services. And that really, really scares us. This also pushed back against harm reduction. Harm reduction is only a dirty word when it works with people who use substances, because harm reduction with sunscreen and harm reduction with seatbelts and helmets is never a dirty word, but it is all of a sudden enabling when you're talking about people who use drugs. So we're pretty resolute that we're not going to stop. And we're going to continue these efforts. We want to continue to see the equitable decline in overdose deaths, and we need to really work on other substance use treatment being equitable and available.
Jill, did you want to jump in, or I also have follow-ups?
I'm sure there's lots more questions. I mean, just to echo what everyone else is saying, I think that we continue. I think it's important to note that we're all saying the same thing, which helps tell you that across the department we're aligned on this. But as we are looking to work with community-based organizations and putting opportunities out into the field, we're continuing to be very explicit about the populations that are at greatest risk for harm and the populations that we want to prioritize in our work. And that's how we do evidence-based public health, and we'll continue to do that.
Great. So someone asked in the webinar today, relatedly, how are you continuing DEI and health equity work when the key partners of provider organizations are facing the coercion of losing all Medicaid and Medicare funding if they participate?
Yeah, I'm not a lawyer. I'm going to preface this by saying that I think that we need to collectively analyze what is coming out of Washington and understand what we can and cannot do. I understand the risks that community-based organizations, community health centers are facing, the funding that is so critical to their operations. I also think that we, the Department of Public Health, are receiving a significant amount of federal dollars. And our lawyers have worked with us to understand what the risk is and how we can continue to do the work, not changing what's happening on the ground, and still receive the dollars from the federal government. And as we've highlighted, and I think Jill, also can speak to, that when we realize the limitations of what we'd be able to do if we were to adhere to or follow what the federal government is saying, we sue. We file a lawsuit. We lean on our partners in the Attorney General's office, and we sue the federal government, recognizing that it's an infringement on our rights as a state to define which populations we think are most critical, how we should deliver content to those populations, right? The information that we're sharing. So I would encourage folks in community-based organizations, community health centers, for us to work together in partnership to understand what are the limitations and what can we do. And when we all reach those limits, that we come together and we work with our legal partners to sue and to push back. Jill, I feel like you've been in this moment, in this experience the most, given the work around PrEP, the work around reproductive healthcare. I don't know if you have other comments you want to add.
Yeah, I think what I would add is that the judge's decision in granting the preliminary injunction rested very heavily on this, right? There is a very clear requirement from Congress that the PrEP program be evidence-based and medically accurate. And we have very clear evidence. We had expert witnesses that, provided information in the case that demonstrate that trans and non-binary youth are at greater risk for sexually transmitted infections, are at greater risk for sexual assault, are at greater risk for adolescent pregnancy and unintended pregnancy. And so to eliminate the information from the curriculum that helps to make the curriculum relevant for those young people and to make the school communities that they attend welcoming by educating all young people about trans and non-binary youth would in fact not be evidence-based and medically accurate. And so it was not possible for us to sort of pick out this one piece and still be responsive to the way that Congress had intended the program to be run. So it was that piece was really key in the legal argument as well.
I also want to ask about the loss of partnership with federal agencies. I mean, I think that is a piece of the conversation that sometimes we are hearing about maybe at MPHA more than usual, but there's the federal administration and what they are doing, but there's also been a huge loss of federal public health infrastructure, agency staff, your federal counterparts, the people like you who have been working in the federal government for maybe their whole career to advance public health. And I'm wondering if each of you can speak to how that has impacted your work, and if there's a particular federal agency that you work with where you've lost partnership. Yeah, I'm just curious how you're thinking about that and what that experience has been like.
I think we can all answer that from probably unique perspectives, whether it be CDC, HRSA, SAMHSA, you name the federal agency that we've worked closely with. I'm chuckling because so people probably don't know this because you don't know my normal background. I'm not in my office. I'm in Burlington because I was having breakfast with someone who I think people might recognize from the cover of the book. And I think what was so interesting is we was at a table with Dr. Fauci and others. And while Dr. Fauci was a career civil servant, he worked for 54 years at NIH, 38 of which he was the director of the National Institute of Allergy and Infectious Diseases. And he recognized the challenging times that NIH is facing right now. he specifically called out how the destruction of the Centers for Disease Control and Prevention is having the greatest impact across public health in our country. Because CDC is so critical to guidance, information, truth, guiding the entire nation and the entire world as it comes to public health. And so I think it's important for us to recognize that the CDC of 2025 is not the CDC that we are used to. I worked there for 2 years. I had many, many friends at that agency when I joined the Department of Public Health. The vast majority of those individuals have left the agency. There's no one there to answer the phone when we call. And that is a really challenging place to be. I do want to recognize there are people within the federal government who remain. There are good people who remain at the federal government. We continue to do what we can to engage with CDC, with SAMHSA, with HRSA, with FDA, with USDA, so that we can get our work done. And we have to keep doing that. And we have to be grateful for those that remain and that are continuing this fight. But we also need to prepare and plan for 3.5 years where people might not answer the phone and where the decisions that are being made may be coming from the political wings of the executive branch and not those that are focused on public health and science. And that I talked a little bit about the Northeast Public Health Collaborative. That is why the Northeast Public Health Collaborative came together. It's not that we think that there shouldn't be a federal infrastructure. We certainly do. We would love to have a strong federal infrastructure. But in this moment, we don't have that guarantee. And so we have come together on our own. I'm going to maybe pass it to Dee because I think of everyone here, she can probably comment the most in particular about SAMHSA and the very close relationship we have with them.
Yeah, it's been heartbreaking. We had such a close relationship from the secretary all the way down to our grant coordinators. They're almost all gone. But I think the more frightening thing is there are some really good people there. I still have contacts that I can try and get through, right, to try and get some answers. But what is really kind of frightening is who they've appointed now at SAMHSA is truly resolute in their disagreement with us around evidence-based practices, and have gone toe-to-toe where they say it's enabling, it's harmful, it's not going to be allowed, and basically like very overt threats to our funding if we continue. And so I feel incredibly supported by the commissioner who, when I came back from Washington, D.C., I said, I might be in trouble because of the things that I pushed back on. He's like, nope, you're not in trouble. But it's very hard because what made me really sad is this was a large I was with all the states were represented, and how many states were coming up to me and thanking me because they're like, we are not allowed to say that. We're not allowed to push back. They've already taken away these services from our children. They've already taken away these services. These services were never allowed. So it's incredibly frightening to know that there's such a change at SAMHSA.
Speaking of federal response and what Massachusetts can do, one question that came in many times from people who registered is something along the lines of, how is Massachusetts building redundant systems to safeguard against funding losses and policy pressure from this new federal administration?
I think the policy question is a lot easier to answer than the funding question. And so maybe I'll start there with the policy. I think there has been a recognition over the past 9 months. I hope there's been a recognition over the past 9 months that it's not just that our federal partners are falling away. It's that the system wasn't necessarily perfect to begin with, right? CDC wasn't perfect. FDA wasn't perfect. HRSA wasn't perfect. And certainly we've exacerbated the problems with the current leadership at those agencies and the way that they're acting. But there was work that we probably should have been doing before 2025. I think that maybe the best example in my brain is the work around vaccines. We have in our state statute, I should use past tense, I'm hoping that the governor will sign something today. We had in our state statute links to the Advisory Committee on Immunization Practices at the federal level that required vaccine coverage by insurance companies of ACIP recommended vaccines, that links school entry to ACIP recommended vaccines. Now, that was likely a mistake looking back, right? We should have given this state an opportunity to evaluate more fully the science, the data around vaccine safety and effectiveness, and to use ACIP as one guide, but not the only guide on how we make vaccine policy, right? So there are ways that we can fix policy going forward. There are ways that we have strengthen our shield law, right? We can make sure that providers and patients here in Massachusetts are protected. We can put into state statute protections around harm reduction and liability protections for those who are doing fentanyl test strips and other types of harm reduction work, right? We can have commitments in our own state policies around racial equity and diversity, equity, and inclusion in our hiring practices and what we do. And so we should take this as a moment to recognize it wasn't perfect before. There are fixes for us to think through and really get to work on the legislative and regulatory work that has to happen. I'd say the funding is much more complicated, right? That even here in Massachusetts, a state that has funded state programs in public health at robust levels for a very long time, we are still very dependent on the federal government. Now, that varies from program to program. If you look at what the Bureau of Substance Addiction Services receives from the federal government compared to, say, the Bureau of Climate and Environmental Health, very different percentage of their overall budget coming from the federal government as opposed to the state. And I think we all need to recognize we're entering, and we are in, it's not even that we're entering, we're currently in very rocky times for state finances. And we're going to have to make some difficult choices. That's the reality of where we are. And that's the reality of the United States of America, where the federal government has, and I believe should, fund a lot of the work that's happening in the states that improves public health and improves outcomes. But we're in for, I think, difficult conversations around how we fund, what we fund, who we fund when we're facing cuts at various levels. I guess I would ask and hope that we can have those conversations openly and honestly, that we can all look at it from many different angles, and that the coalition that is here, that MPHA has pulled together, is willing to sit at the table and acknowledge the really difficult times that we're in.
Thanks, Robbie. I want to turn to our local public health infrastructure. So we are losing a lot of federal public health infrastructure. We're so grateful for all that the State Department of Public Health is doing. And we had a huge win in Massachusetts last year. Robbie and I missed this conference because the SAFE 2.0 legislation was being signed into law exactly at this time. This was MPHA's top priority campaign for many, many years to shore up our state local public health infrastructure. We did not mean for it to be prescient. I think it's one of these things that was on the list of things that we should have been doing and were doing for many years. And we are grateful that this happened a year ago and that Massachusetts at least is advancing in the local public health space. Robbie, can you talk about what is the role of local public health in this moment in time and how local public health is helping to keep Massachusetts moving forward?
Local public health is everything, right? We can say a lot of things here at the State Department of Public Health, but the work gets done by the locals. It's the local public health workers who are educating every day, who are building trust. It's the local public health nurses who are administering vaccines for those who are homebound, right? It's the local public health folks who are linking folks into early intervention services and WIC services. We're hopeful that it's local public health that's going to be engaged in home visiting and levels of maternal care and understanding where people should deliver and what people need postpartum. Right? So local public health is so critical to everything that we're doing. I think that we we are going to have to continue to work with local public health to understand what are their needs in this moment. Right? What do we collectively need to advocate for? Some of that is funding, I will acknowledge that, but some of that's also, what types of authorities does local public health need? What types of training does local public health need? How does local public health need to better connect with community-based organizations in the work that we're doing on the ground? Because the stronger we make local public health, the healthier our Commonwealth is going to be. I will show my bias here. I think pretty strongly that local public health is best served through our shared service arrangements and through the regionalization that is really codified into law through SAFE 2.0. What I've seen traveling the state and meeting with various regional organizations is truly remarkable. These are groups of towns and cities that have come together that maybe historically have been at odds with each other and now are working together and collectively improving the lives of residents across wide areas of this state. I think we're seeing that in the way that they're managing substance use disorder and connecting people into treatment and to care. We're seeing it just in the ability for people to inspect restaurants and to know that there's someone that they can pick up the phone and call, the support that they'll receive. And we're seeing it really raise the bar for those that work in local public health. The training that is part of our shared service arrangements and the training that's part of SAFE 2.0, right, has meant that we've elevated the profession of public health at the local level. And I think that's an amazing thing for this state and for public health writ large. So, you're right. A year ago, we wanted to be here, but we got to do something really amazing, which is we got to watch Governor Healy sign into law something that will truly transform public health in Massachusetts, something that is the envy of many other states in New England. I think folks know this. A lot of states in New England have this very decentralized public health system. This is what we've come from. But what SAFE 2.0 does and what MPHA, this journey that MPHA has been on, is really remarkable and is going to keep Massachusetts in the lead of public health for many, many years to come.
Is there a possibility that local health departments may not continue?
I hope not. I hope that local public health remains. What is inherent in the local public health system, right? And what we have is that the individual in Athol knows that community best. And yes, there may be shared understanding of what's happening in Gardner or maybe what's happening in other parts of Northwestern County. But at its core, I do believe that the individual communities need representation, need someone that they can trust. They need someone who speaks their language. That's what local public health is doing. What SAFE 2.0 is trying to do is provide supports around that, right? So that you're not the only public health-minded individual in a 60-mile radius, but you actually have folks around you that you can call that will support you as you're facing difficult times. That's the spirit of SAFE 2.0. It's not about the destruction of the local Board of Health or local jurisdictions having control. It's about the idea that we're stronger together.
Great. And for anyone who's on the call who wants to know how you can plug in to support local public health, stay tuned for the policy update. We have some great actions that we need. It's going to be a full court press this year to make sure that local public health and everything else that's important gets funded. So that's coming later for folks. One question that we got a lot before in the registration and is coming up in the chat right now is about single payer healthcare and Medicare for all. So obviously we have these huge Medicaid cuts coming from the federal government. The projections are that 300 to 350,000 people in Massachusetts will lose coverage over the next decade. Even before that, and I think maybe I'll just speak from my personal experience, navigating the healthcare system is tricky, even if you are the deputy director of the Massachusetts Public Health Alliance and you have a law degree. If it's hard for me, I can't. I know it's hard for everyone. And it seems like Medicare for all, single payer healthcare, it's been part of the conversation, but at least MPHA is hearing much more about it from our base right now. So curious what your thoughts are on single payer.
think you meant me. Although I'm happy to have Dee, Jill, and Fifi jump in. Look, I don't want to speak for the governor and for the administration on this answer. I think that it's her responsibility to outline her policy on single-payer healthcare. What I do think we can acknowledge is that when we make services universal, when we give access to individuals the care that they need, people do better, right? And while I think there are a lot of strengths in a single payer healthcare system, a system that really eliminates the barrier that people might have to going into healthcare, getting what they need, and walking out knowing that they're going to be healthier afterwards, right? What's sort of inherent there is that the services are available. And if I think about this from the perspective of the Department of Public Health, our job is to provide access to people for everything that they need. And where we're leaning in is in the identity of programs and the support for programs that create that universal access, right? So, I think I mentioned earlier home visiting, and we're on a journey to bring home visiting to every postpartum individual in the Commonwealth of Massachusetts, regardless of insurance status, regardless of where they live, right? That would be a universal benefit that we can provide to everyone. Similarly, we have currently a universal benefit of pediatric vaccination for every child in the Commonwealth, regardless of insurance status, regardless of where they live. Those types of universal programs are essential, and they're going to be even more necessary over the next 3 years. So as you noted, Omi, right, we are projected to see a significant number of people lose health insurance or be unable to afford the health insurance that they currently have as early as January of this coming year. And so what we can provide to people in a universal way, from our point of view at the Department of Public Health, right, we are going to continue to do that. And I think you can see that in the work that Dee does in BSAS and making sure that everyone has access to methadone. Everyone can go to an OTP. It doesn't matter your insurance status. We will get you the methadone that you need. You see that in the work that Jill is doing around reproductive health and making sure that no matter who you are, no matter where you are, you can access abortion care. You can access what's necessary for you and for your body. So I know I didn't answer the question specifically for folks who want me to go on the record speaking for the Healy Driscoll administration on the single payer healthcare system. I'm not sure that that's my place. But I do think that we are aligned in the mission, which is universal access to essential healthcare.
Thanks, Commissioner. There was also a question in the chat specifically about the intersection of Medicaid cuts and the attacks that immigrants are facing in our state. And I know at MPHA, we think a lot and worry a lot about people who are getting hit from all sides by these policies. No community is a monolith, and people are experiencing all of these policies very deeply. So given anticipated Medicaid cuts for vulnerable populations, especially refugees, immigrants, and asylum seekers, what strategies are being considered within the healthcare systems and throughout community partners, and I think in concert with DPH, to accommodate these groups and mitigate long-term health consequences?
Yeah, I'll name a few things, and I feel bad, Fifi, Jill, Dee, if you'd like to jump in, you should come off mute and certainly jump in on this. First I'd say that we are so dependent on and so grateful to our community health centers across Massachusetts, who disproportionately see in their exam rooms immigrants, refugees, asylum seekers, those who maybe are going to face challenges in having healthcare access and health insurance coverage in the coming years. And so we are thinking about ways that we can further support community health centers. Maybe that's working in coalition with them to find community-based organizations near and around them that can provide services if for some reason the community health center can't continue to do so. Maybe that's identifying state dollars that we can fund the community health centers with so that they can continue to provide this care, even if they're not receiving federal reimbursements. But I think we are going to get through this if we all work together with the community health centers. They're so critical to the work that we're doing. I also think that, we're really lucky right now, and I really mean this, to have Mike Levine at the head of Mass Health, to have Audrey Gesser Morris at the head of the Health Connector, to have people in these roles who care deeply and are really committed to maintaining access in Massachusetts. Now, I don't know if anyone has the answer right now, but the two of them working together with newly appointed Undersecretary Amy Rosenthal, for folks who don't know, she started this week at Executive Office of Health and Human Services. We have three people who have their entire career thought about access to healthcare and how insurance can be used for good. And so if any state is going to get through this, it's going to be Massachusetts, because we've got the right people thinking this through. We are in for some really challenging times. We have to admit that to ourselves. And then we're going to have to place some trust in the organizations that we know can get us through this. The community health centers, Mass Health, the Health Connector, right? Healthcare for All, organizations that have been committed to insurance coverage and access for a long time.
Can I jump in? Just, so I agree with everything that the commissioner just said. I'm not sure if everyone is aware, but BSAS is the payer of last resort for those who are or underinsured in Massachusetts to ensure that they receive substance use care. And right now we're spending about $86 million a year on those services for that. What worries me is when, you mentioned 300,000 people losing health insurance and the requirements that are going to make it very hard to even stay on. We have people who are finding it incredibly difficult to re-up once a year, and now the new requirements to do it twice a year, and the proof on providers to show that that person's in treatment, and all of the things that are coming. We're going to have more individuals who are going to be underinsured or uninsured, and that is going to really limit BSAS, if we spend all of our money on ensuring the core services, to do anything thinking outside the box, to do anything evidence-based, to really put some of our funding towards innovative practices, which we know we need to continue to invest in. And so that is one of the things that concerns us greatly, being the payer of last resort for the state for substance use.
Yeah, that is very concerning. And Dee, we had oops, I went out freezing. Question from an audience member about initiatives that are coinciding with substance use disorder and people experiencing homelessness, particularly men in Massachusetts. It's great seeing a decrease in overdose deaths, but homelessness persists in these groups. Can you speak to work that BSAS is doing?
Oh, yeah, absolutely. I feel like one of the crown jewels that we don't talk about enough is in 2021, we decided to invest heavily, not with federal money, thank goodness, in low threshold permanent housing or housing first model, where sobriety is not a requirement. And right now we have permanently housed over 650 individuals who would not actually have ever received housing through HUD. So that, and we contribute about $12 million a year to housing stability supports, which matches the HUD money that individuals get. So if somebody has a substance use disorder, does have a HUD voucher, these monies can provide the service supports and matching monies. So we know that sobriety is or recovery is really hard to find, or even less chaotic use is really hard to find if individuals do not feel safe and they do not have a place to lay their heads. So we are committed to housing, even though that's not what BSAS does. We're really concerned about the NOFO that came out that is talking about the new requirements for HUD that we were talking about yesterday, where up to 3,600 individuals who have been permanently housed for years and years could lose their housing based on these new housing rules that we were talking about yesterday. So I know there's a lot of conversation about that, but we are fully committed to permanent supported housing. And, and we have like a 95% success rate for individuals who are there. We've also had, I think, one overdose death since 2021 in this housing, and like I said, we find people are, their use is less chaotic. they're more interested in finding treatment. There's harm reduction that's available to them there. And it's been a real success. And right now it's 650 individuals in Massachusetts.
Wow, thanks, Dee. That's really heartening. Nice to sort of have some positives to reflect on and think about. I am just going to announce to my colleagues, I'm going to take moderator's privilege. We're going to go 5 more minutes on the questions, and then we'll turn to the next segment. But we have a lot of students who've joined the call today, and these are uncertain times for all of us, and I think especially so for students who are studying public health, who are wanting to go into this field at a time of great funding uncertainty and real policy shift. Given this challenging climate, how do we encourage students to continue to study public health and believe that there will be work for them upon graduation?
Yeah, look, I think now there is no better time than now to be in public health. Now is our moment, right? It's actually the moment when we can do good, when we can change the system, when we can fight back. So I think this would be a really exciting time for students. And I recognize there's uncertainty about where you get your job afterwards. And I might recommend that you don't apply for a job in the federal government right now, because I'm not sure that it is going to be the most stable place for you to be. But I think that public health is so much bigger than just governmental public health. It's so much bigger than having a job at a state department of public health or the federal agencies. It's about working at a community health center as a community health worker. It's about spending time at a substance use treatment center or at a harm reduction center and engaging with people and educating people. There's a lot of work that public health does that doesn't involve a government paycheck. And so I encourage students to stay the course and to use this as their moment to find the issue that really drives them and to work hard every single day to fix that issue.
Thanks, Commissioner. I think that's exactly right. And I get this question also a lot about what students should be doing and thinking about. And I was talking recently with my partner about this, and they had I thought, a great frame that a lot of things are breaking right now, but let's also be honest, things were very broken before. It's not just that, these systems are in part crumbling so fast because there were cracks in the foundation. And I think now is a really, as you're saying, Commissioner, important and exciting time for people to reimagine what these systems should look like as we build them back. We don't necessarily just want to go back to where we were 10 months ago. Things were not working very well for a lot of people. And so this is, it's a hard time, it's a painful time, but it's also an opportunity to imagine the systems that we actually need and will actually serve our people and work towards those ideas. Maybe very last close out for each of you to leave us on a little bit of a higher note as we continue the fight. I'm curious. I know that you all must be tired. I am tired. Everyone is tired. There's a lot of work to do. And you keep showing up. You show up for us all the time. Every time we ask any of you to speak at something, which is frequently, you always say yes, which we are so grateful for. I'm curious for each of you, what gives you hope and energy to keep up the good fight?
Yeah, I'm happy to start. There are over 300 people on this webinar right now, right? And that's inspiring. I show up because I get so much energy from being with so many other people and being in coalition with everyone. So it's you that drives me. It's the reason that I get out of bed in the morning. It's the reason that I trudge home late in the evening. It's because of the people in this state that have time and time again demonstrated their commitment to this cause and to the work.
I've been doing this work for so long, I just couldn't imagine not doing it. And I think this is the most important time. But as a person in long-term recovery and somebody who leans heavily on, my community of people in recovery, but also the people that I am committed to care for who are still using substances, this is important. And I am energized by people who are so committed to this group, who love this group of people, who see them as humans, worthy of dignity, worthy of care, and they're fighting every day. So how can I sit back and feel bad, right? I feel incredibly grateful. I'm so grateful to live in Massachusetts, full stop. But that's the reason why I get out every day. This is my community, and I'm not going to stop fighting.
Can go next. As I mentioned in my talk, we made a promise to the Commonwealth that we will keep them safe, healthy, and to bring that wellness and well-being in the communities, we need to do it every day. There always be work in public health. And for me, it's very personal. As a person of color who sees numbers that aren't improving, I've been in public health now in Massachusetts for more than 20 years. And the numbers I saw 20 years ago are the same. Actually, some of them are getting worse. So for me, until those gaps are closed, there is work for me and anyone else. This is about the people. This is about, helping people. So I am committed. I will remain committed until I retire. Don't know when that, but I'll keep fighting the fight because it's really good for our residents. So.
Yeah, I would echo all the things that people said. And also, we are still having successes, right? It is a challenging time, it is a difficult time, but there are things that we are still able to do and still able to move forward. And I don't think I would be able to get out of bed every morning and continue to do this work if we didn't, feel like there are things that we were continuing to affect that make positive change. And so I'm, so grateful for my colleagues and the support that enables us to do that. And to that end, I'm going to drop a couple of links in the chat to resources that I mentioned when I was talking that I hope you'll share with everyone, because we have put together some great resources and want to make sure that they get out there.
Thanks, Jill. We'll certainly share those out also in the follow-up materials. Thank you so much, Dr. Goldstein, Dee, Jill, Fifi, for joining us here, for giving us so much time, for your frank and candid answers to the questions. I think everyone should know that nobody saw the questions in advance, and so it's really something to have government leaders like you all come and be honest and open and just speak truth to all the questions that have been asked. And we know now not to take that for granted, and just want to thank you all so much for all of your work, all that you're doing, all of the passion that you're putting into keeping Massachusetts safe and healthy. Please show love for our DPH colleagues in the chat. DPH folks, you're off the hook. We'll let you get back to doing the good work. Thanks so much for joining us.